Welcome back, everyone. It is now my distinct privilege to introduce our keynote speaker and fellow REF trustee, Dr. Nicholas Bernthal. Nicholas Bernthal is the professor and chair and executive medical director and the Jeffrey J. Eckardt Endowed Chair in the Department of Orthopedic Surgery at the David Geffen School of Medicine at UCLA. He graduated magna cum laude and Phi Beta Kappa from Princeton and received Alpha Omega Alpha honors from Cornell University Medical School. He did his residency in orthopedic surgery at UCLA and fellowships in orthopedic research and musculoskeletal oncology at UCLA and the Huntsman Cancer Institute, respectively. His clinical interests are bone and soft tissue tumors, and his NIH-funded laboratory is pioneering new implant coatings to prevent surgical infections. I've had the privilege of getting to know Nick personally. I was a visiting professor at UCLA a couple of years ago, and I've been working closely with him on the REF board. He is really a rising star and in our specialty, and is someone who I would consider a quadruple threat. A rare individual who excels in clinical practice, also in education, research, as well as administration. So it's my distinct pleasure and honor to introduce Nicholas Bernthal as our keynote speaker. Dr. Bernthal.
Thanks, Josh. Really appreciate the opportunity. I'm going to pull some slides up and making sure those are now projecting out for everybody. Can everybody see these slides okay? Thanks. I had the privilege of talking about a little bit of research, a little bit about the OREF, and for me, these things always start with looking back before you look forward. And I was actually as a chief resident in 2011 at the ORS Pacific resident paper competition when John Healy gave this talk, the keynote address. And I have really distinct memories. It was an introduction to OREF for me. It was jump-starting an academic career. I remember the meeting well. I also learned not to give a long cancer talk to this audience because that may not go over so well. So I will not give a long cancer talk tonight. The disclosures here, as you see, that a few actually are relevant. I'll get to those. But, I think we can start with this picture. And there's an assumption in this talk that both of these gentlemen have had successful careers. And one is John Charnley, sort of the father of arthroplasty on the right side, and then Marshall Urist, who founded our orthopedic department here at UCLA, who's really the father of biologics and orthopedics, and is one of the only orthopedic surgeons ever to be a finalist for the Nobel Prize. What makes them have successful careers? And this is my mentor, Jeff Eckardt, and he would always show this slide and say, this is my 35-year career on one slide. He would say, here's the survivorship of my patients with cancer with different grades of disease, and then the black line is the survivorship of my implants. You can sum up my whole career in one slide. And then he would say, if at the end of your 30-year career, your curves are no better than mine, you failed. So we have to humbly say we have to move curves up. That has to be the point of what we do. It doesn't matter what curve you take on, but we focus our careers on moving a curve up. Atul Gawande said if he gets hit by a bus tomorrow, his patients won't even be postponed. Another surgeon would step in and take over. The reason to do research and to write is that it makes me feel not entirely replaceable. If I didn't write, I don't know if I'd do surgery. It's an important concept. So when we give these talks, usually there's some themes. The speaker's very proud of him or herself. They say, do it like I did it. And I'd say the point of this talk is really from my end to say, follow your path, but follow a path, and we'll talk about that. I'm very proud of both my brothers. One of my brothers is an actor, one's a businessman. Both of them took on careers that were all risk. They had no assurances. It was not about getting the right grade and getting into the right residency program. Every day they were worried that they wouldn't have a job the next day. They learned to take risk, and it's something we don't do very well in surgical training. So when we look at this, we talk about surgical training and learning language and basic skills, and we graduate and practice. It's really still this apprenticeship model in surgery. But what we're talking about tonight is the scientific training we hope people go for. And that's learning languages and basic skills. But then eventually, it's not about modeling the behavior. It transitions to innovating, challenging, creating. It's all about risk-taking. We have to get on this risk-taking train early. Isaac Newton developed calculus at 23. Steve Jobs founded Apple at 21. Napoleon had conquered Italy by 26. What happens over time in life is your risk allocation goes down. Your willingness to take risk with time gets less and less because you feel you have more to lose. So these resident research competitions, for me, this is the heartbeat of our field. This is getting people at the right time to push them forward, to be willing to take these risks. Unfortunately, even when studied, doctors are not risk takers. We are risk-averse professionals in general. And as you see, your years in practice, this goes down over time. You will continue to be willing to take fewer risks, not more, as time goes on in your career. And in modern medicine, this is even worse. You've got patients and families and RVUs and administrative roles. The older you are, the more you see what you have to lose and the more you fear what that loss might mean. So now is our time. The one good news is that surgeons are willing to take more risks than internists and pediatricians and anesthesiologists. So that's good. Among the field, among doctors, we are more willing. In our training, everything we spend time doing is about risk deference. We have to tell our patients what's the risk and benefit of every little thing we do. We are all about fearing that risk. So the fundamental question of this talk and what I want to spend the next 15 or so minutes talking about is how do we expect to develop risk-tolerant innovators that move curves up if everything we're doing is taking a phenotype that doesn't like risk and then driving risk aversion as behavior into our trainees? And that's why I think this sort of session is so important. So we talk a lot about training surgeon scientists and or scientific surgeons. I'm going to define both of these. These are totally my definitions. This is not a hard and fast rule, but I define a surgeon scientist as someone who's really wearing two hats. They're trying to support a laboratory or research funding. They're trying to compete for federal funding. And a scientific surgeon is someone who studies clinical practice in a way to advance care. They may collaborate with these basic scientists to innovate, but they're scientific about how they study their practice. Both of these start with a clinical problem. So for me, this started in 2010 when Eric Johnson, our trauma chief, a very well-known father of AO, said, tumor surgeons are idiots. They're simple bone killers. All they know how to do is kill bone and throw in sticks and cement. And this tongue-in-cheek comment from our trauma chief sort of made me look at this practice, and I was so proud of what we did. We take them out, we put these beautiful metal implants in, but then when I looked at the x-ray, I sort of thought, maybe he's right. Are these just sticks and cement? Has our field not really advanced? But then I went into clinic with Dr. Eckardt and looked at a patient on the other side of this. Here's a patient 35 years out. He's a painter, has a good, successful profession, climbing on roofs, painting houses and buildings, 35 years out with this stick and cement. So this gets complicated, right? We look at these patient versus prosthetic survival, and we have to take home point number one, which is, well, maybe a well-done hunk of bone removal with stick and cement reconstruction does pretty damn well when it's done correctly. This has really important implications. And as you, as young surgeon scientists or scientific surgeons, are tackling the questions you want to tackle, you have to tackle meaningful ones. Right? In medicine, we know aspirin works for heart disease, penicillin for strep throat. The Charnley hip replacement is pretty good and open appendectomies are good. It may not be the place to move a curve up if you're taking on a problem that already has pretty good solutions for it. We have to tackle the big questions and the big problems. So we have to evolve. So let's go back to the curve and find a drop. Why does it drop? Where does it drop? And ask that question. Eric Henderson at Dartmouth and some of his colleagues answered that for us about a decade ago, where he took endoprostheses and said, why do they fail? And if you look here, type 4 failure, I know it's small, but is by far the largest source of failure of these implants, and that's infection. This is the number one cause of implant infection in tumor surgery. And frankly, when we move into arthroplasty, this is where the money is, right? Cost related to a single post-arthroplasty infection, average about $145,000. And when you sum direct and indirect costs, this is over $8 billion of spending we do every year on implant-associated infections. So the path of the surgeon scientist starts with the clinical issue. What do we know about this? Well, we know we try and keep the rooms clean and we give perioperative antibiotics. Since 1970, Fogelberg did this beautiful study that said, give penicillin before you start. Now we give Ansef. That's great. That's what we've learned. That's 55 years ago, and that's probably the last thing we agree on as far as infection prevention. Antibiotic impregnated cement, some databases show decreased infection rates. Some prospective studies show no difference. We still debate it. Vancomycin powder, I call this sort of the Parmesan cheese on top of the wound. Some people have shown it has some efficacy. Some people have argued against it. What's the bugs that end up on the back end of this? Still debating it. So we decided to answer this question 15 years ago with preclinical modeling. We really wanted to go in, and the take-home point for this group is this was a project I started in residency. And I'd say it still forms the framework of a lot of what we do and what I do in my lab now, 15 years later. So we set up an animal model. I'm not going to belabor it because these are actually slides I showed at the resident talk in 2011. This is putting an implant into an animal. This is a mouse. It's a fluorescently modified mouse, so we can track the neutrophils and the immune cells, the macrophages. Then we can put in a bioluminescent strain of bacteria, and we can track this in real time. We took pretty pictures of the implant. We had very nice CT scans showing we were putting the implant where we thought we were. And we could follow these infections over time, tracking bioluminescence and then fluorescence for the immune response. Checked histology and confirmed we did what we thought we did, and took VPSEM. We wanted to see what the biofilm looked like. Then we looked at the osteolysis. We wanted to look at these pits that are marked by red. And then we could correlate the whole thing on these very nice CTs tracking inflammation, infection in real time. So what did this teach us? This project we presented to the OREF 13, 14 years ago. First, we've learned over time we really need to know where to look for bacteria. We started studying the bone in these mice, and then we started studying the bone in patients. And as it turns out that if given time, staph, this bacteria that is non-motile, that isn't supposed to move anywhere, actually is able to squeeze itself into canalicular networks in cortical bone. We identified this. The group in Rochester identified this. We started looking at this more closely. But all of us surgically go in and debride cancellous bone. It feels good. It's really gratifying to scoop it out with the curette. The problem is that staph is hiding in the cortical canalicular networks, which we're not getting with a curette. This explains anatomically how staph has developed a way to persist in the environment we treat it. The Rochester group has studied this beautifully, showing how in these submicron channels, these staph can exist and then come back out of the submicron channels to reinvigorate a staph infection. So we started looking for solutions. How do we address these networks? How do we deal with biofilm? How do we address polymicrobial pathology, which we've come to be interested in? And remembering that bacteria are smart. I don't want to spend a ton of time talking about our research, but I think systematically looking about how we approach it. We found partners at the Department of Defense. The only people who care about infection as much as tumor surgeons, as trauma surgeons, especially military trauma surgeons. As soldiers were coming back with Acinetobacter infections from wounds in Iraq and fungal infections in Afghanistan. We learned so much partnering with them. We developed smart antimicrobial coatings, things we could apply to implants. We went through the FDA trying to get this through with improving practicality and regulatory. And this article that was published last year in Nature Communications was really our attempt to deal with FDA concerns. We look at interoperative versatility. How do we apply these coatings in a way that lets it be agnostic to the antimicrobial you use? That way, in an environment where it's a fungal infection, you can load this polymer with antifungal. In an environment more traditional in our hospital settings, antibacterial. We've started to develop ways to target established biofilm. We've partnered and we've developed antibodies that attack eDNA, which is a key structural element in biofilms. And this is fairly agnostic across bacterial biofilms. So we've looked at these DNA binding protein scaffolds. We're able to attack this and break it down. When you look at what a biofilm looks like, if you leave it in a patient, it's this three-dimensional structure that's fungating off and the bacteria is hiding within in this senescent state. After we treat with the antibody, this is the same magnification you see on both sides. It breaks down the three-dimensional structure by removing that extracellular DNA binding protein. And it allows us to treat this with antibiotics, making biofilms more susceptible to systemic antibiotic treatment. And the fun part about this is we could do this study, and in our mouse model that we had developed, again, a resident project, we showed this massive reduction in infection. So then we were able to take this to patients. We did the phase 1. Here's the preclinical study that was finally published in 2023. The phase 1 study results were already published by 2024, and we're on to a phase 2 trial of this antibody. Really exciting translation. So switching gears to this scientific surgeon, this is Dan Oakes. Dan Oakes is a USC surgeon who used to be at UCLA. And what is a UCLA guy doing celebrating a USC surgeon? Well, Dan Oakes taught me a really important lesson. He figured out by just watching his patients closely in 2010 that this ASR hip wasn't working well for him. And he figured it out with 64 patients. This is before registries picked this up in Australia and in other national registries. Dan Oakes was so attuned to his patients that he said, my patients seem less happy. 9 months into using an ASR, he said, something is going on. It's squeaking a little too much, grinding. And we published this before the registries had picked this up. It's such an important lesson of being attuned to the patient. And so for me, I look at orthopedic oncology, and these type of cases are my bread and butter. And we celebrate these long-term follow-ups. This is a patient with a total femoral replacement sending me pictures of all the things I tell her not to do, and she sends me pictures after she does them. This is amazing. It makes us celebrate our field and our patients, but you have to pay attention to the failures. Why are they failing? In whom are they failing? And this is really the key to moving that curve up if we're talking about implant survivorship. Will Rogers, a great LA icon, says there's 3 kinds of men: the one that learn by reading, the few who learn by observation, and the rest of them have to pee on the electric fence for themselves. This is the key. We got to learn where our failures come from. And if you can learn from someone else's failures, it's even better than your own. Eric Henderson and Doug Letson, 2 of my dear friends from at Moffitt at the time, looked at why these endoprostheses fail in young kids. And they figured out it's directly proportional to age. You put them in young kids, they're much more likely to fail. So when we look at kids now, we say, okay, if someone's going to fail with our bread and butter endoprosthesis, what other options do we have? How can we avoid putting them down that path? This is a 9-year-old with a Ewing sarcoma who I saw. And when we look at this, he got opinions from all around, actually international opinions as well as national ones. Some folks wanted to do turn-up plasties and rotation plasties. Some wanted to do proximal femoral replacements. But we knew this patient was at a high risk for failure. So we started looking at other options. We wanted to look because there's something we could do to innovate in this type of patient. So we take the tumor out as is typical. We dissect out the circumflex vessel going into the femoral head. This is something no one even really talked to me about in my training, but it seemed conceptually feasible that we could dissect this vessel and protect it going into the femoral head. We get our plastic surgeons to go in and take a vascularized fibula. We take that and put it into an allograft. So we use what's called a campana technique you'll see here. You basically create a trough for this vascularized fibula within the allograft. You can fracture the allograft as long as you keep the medial cortex intact. And you can see here, you can actually fit this in, leaving the vascularized portion of the autograft long on both sides to bridge those cortical junctions. And then we take this, put our plate on, and start talking about fixing this in place. Hopefully you have a fellow who's as good or lucky as mine was that day and placed 3 screws into the back of the femoral head. We had templated this at 2, that we only had room for 2, and he put 3, avoiding that autograft. The microsurgeons come in and hook up the anastomosis. And suddenly you have innovation in surgery in a patient. Because we picked the right patient, this is a patient who you take that risk because they're at a very high risk for failing with their endoprosthesis, their growing prosthesis. This is the patient we want to take that risk. Here's him pitching 2 years later in the Little League World Series. And I'll skip the video in the nature of time, but he goes on to have a very successful game and hopefully is on his way to the Dodgers. We look here, where else can we innovate? Well, we know that proximal humeral replacements have been a problem. When I was in fellowship, this was a success. 30 degrees abduction, 30 degrees forward flexion was this was a success story. So we partner with our shoulder surgeons and say, how do these newer technologies with reverses allow us to take endoprostheses and get function we never would have expected before? This is an area for innovation that we choose to take this because these are patients who don't have the results we want if we do the status quo. Here's a patient, we were told that you can't do this if you take the deltoid insertion off. Here's a patient with full range of motion with the deltoid insertion completely off with an endoprosthesis and a reverse total shoulder. These are patients that we partner with to innovate because these are patients who are set up for bad outcomes with the standard of care. Choose the big problems, choose the areas that we need to make movement on, not the areas that we have good solutions. Here's a patient doing something I really wish he didn't do on a reverse with an endoprosthesis. So to kind of circle this back, the way we innovate is in surgeries, we learn different ways to address problems. We partner the right patient with the right surgery. We establish outcome measures and we follow those results closely. And so finally, I just want to end with this. How do we advise residents who want to take this path? They want to be the next Josh Jacobs. They want to be surgeon scientists who go down this path. Well, you need some things. You have to look for this when you go job hunting. You need environment and mentorship and momentum and funding streams. Because when we talk to junior faculty, the big thing is research is applauded, not supported, and RVUs are king. So we studied this. We tried to figure out which departments have environments that this is successful in. And we look and we see departments that have research directors with funding have young faculty that get funding. Without that position filled, it is extremely, extremely indicative of an environment that is supportive for young faculty who want to do research. Lee and others have alluded to this earlier study. Work through the OREF. This is an environment that gets you on the pathway to this career. 22% of all OREF grant winners went on to receive an NIH grant. This is crazy when you think of how few orthopedic surgeons are NIH funded. Our initial study showed 46%. When we've updated this now, 48% of career development award winners have gone on to have federally funded labs through the NIH. This is such a unique opportunity, and I'm biased. I alluded to this resident event I was involved in, but these were the OREF awards. I used literally every single mechanism the OREF offered to build enough momentum that larger funding sources would start to think I maybe had a chance. So how does this work for you? And the question I get most often from graduating chief residents, where should I take a job if I want to do an academic career? So I just, bear with me for just a couple of slides here because I think this is interesting for a job search, which you're all interested in. You can look for the magnanimous chair, the person who says research pushes the field forward and I'm just going to give you money to do it. I don't care what happens or the financial implications. My bet is you're going to find few of these when you actually go around and just say, you got a blank check, I'm betting on you, go get them. It's a hard world out there for the chairs too. So let's do a quick case study and let's assume a starting salary is going to be $350,000. This is a number I pulled completely out of a hat. And then look at the other costs that a department sees in hiring you. Conservatively, without any research support, a department is seeing $750,000 of cost to hire you at that $350,000 salary. So if you go look down this K award path, in the surgeon, you say that the NIH just covered a little less than 1/3 of my salary. This is a NIAM support of $100,000 for 50% time. In a department's eyes, the NIH is covering about 20% of the cost, but asking for 50% of the time. So how do we reconcile this? I think a lot of chairs look at this and stop. Their math stops here, and they say, this does not make sense. You got to make up the money some other way. I have a slightly different argument that I'm going to share these slides with anyone who wants it when they're negotiating their first contract, because I think it's actually not true. Clinical surgeons use up shared resources, clinic space, OR, and patients, depending on your system. So how does that add up? Just work quickly through this, and again, happy to share the slides, but Surgeon A is a full-time clinical surgeon who's in clinic 2 days a week and in the OR 2 days a week, and then 1 day of being always available, which every young clinician wants to be. Surgeon B is doing research. They've got 50% protected time, and they're in clinic 1 day a week and in the OR a day and a half a week. If we take out what they do with patient volume, you're going to see that based on this, Surgeon A is going to see 80 patients a week, and they're going to do 6 cases a week. And Surgeon B is going to see 50 patients a week in these clinics and do 4.5 cases a week. Okay. These are numbers we have checked in our experience with K awardees. We've gone to every institution. It is pretty darn close to this, almost irrespective of your institution. The problem, and that people don't recognize, is that Surgeon B, by being in the lab that day, just opened a day of clinic space and a day of ORs for Surgeon C. And that's the part that nobody factors in. So utilization globally for a department actually increases. Surgeon B runs a more efficient practice because Surgeon C is running that high efficiency practice in what you just moved out. So a funded surgeon in my department, my experience with this, 100% of research funded surgeons are in the black. They actually are the most efficient surgeons I have. We spend a lot of time optimizing their clinical practice, so it's highly efficient in that 50% time. By the time you add up all of these things, the cost keeps going up. We've got benefit rate and dean's tax. The ascending cost of doing business academic goes up, up, up. And actually financially successful surgeons in the future are people who have different buckets of revenue, and research can be a very good bucket. It can be good for philanthropy. It can be good for hospital support. And we try to kind of make these buckets support. So we learned in the pandemic, everybody's got bosses. And when you're on Zoom, always have your camera on with your boss's boss. Chairs have bosses. Remember that. They've got deans and CEOs and vice chancellors. And if departments are evaluated on these 4 pillars. So if you want to be a surgeon scientist, you actually are the currency to upper campus for academic chairs. You have to find a chair that sees it that way and that sees your work and your success as totally aligned with theirs and their departments. K grants are absolute home runs. They achieve both 2 pillars, research and education. These are absolute home runs for your career. So the final slide here around financial math, surgeon scientists add texture, depth, and diversity to academic programs. They can concurrently suffer with their own bottom line while improving a departmental bottom line. And they provide an additional revenue stream for the department long term. Again, I talked about the K Award, and remember, OREF and other organizations have these very valuable supplements if you go this pathway to help. So what can you do as you start your career? You're doing it. Write, read, think, present, develop diverse mentorship teams, go after big questions, never allow the routine to turn your brain off, stay active with the OREF and build momentum, because momentum, big success. So that risk at the beginning of this talk, how do you lessen it? Well, you can either don't take the risk or you build momentum. So taking risk is less risky. We always talk about Dr. Seuss and the waiting place. Don't sit in the waiting place. Get started now. Taking the risk will be harder later. We have to beat the curves of our predecessors. And so being a surgeon who does science is the best of both worlds if you look at it through the right lens. It's not I have twice as much work. It's I have a creative outlet to push the field forward, and my family won't starve if I don't get this grant. You're lucky to be in this opportunity and to have it, so leverage it. We talk about orthopedic training now as a launching point, and we really believe that's what it is. So with that, I will conclude and say thank you to the OREF, to the board, who it's been a privilege to work with, and really congratulate all of you on incredible research. It's been great to see it presented, and I look forward to seeing who the next great award winner champion is.